Good morning, everyone, and welcome to Friday number 2 of the 2020 Triad Conference, sponsored by Triad of Wisconsin and RSVP of Dane County. My name is Mike Thompson, and I'm the Triad Coordinator with RSVP of Dane County. Before I introduce our first presenter this morning, let me say that if during the presentation you have a question, please enter it in the chat box at the right side of your screen. I'll be keeping an eye on it and bring your questions to Tracy's attention at the end of the presentation. She said she's going to leave about 10 minutes, and so hopefully we get to as many as possible there. Second, if you did not receive the slideshow and handouts in yesterday's email, you can download those from the handouts box also on the right-hand side of your screen. Third, it's no longer necessary to complete the survey to receive the CE hours. So if you're expecting CE hours for attending, we'll be looking at the attendance role that GoToWebinar provides. And so don't worry about that survey unless you'd like to give us some information, about how we're doing, okay? We really do prize the feedback we get from the survey. And so please, if you would, take a couple of minutes and fill out the survey. This morning, we're very fortunate to have with us Professor Tracy Schroepfer from the School of Social Work at the University of Wisconsin-Madison. Tracy?
Thank you, Mike. And you pronounced my name right. Most people don't.
Thanks, Tracy.
So I'm Tracy Schroepfer, and I am a professor at the School of Social Work, as Mike said, at the university. And of course, we're working remotely from home as well. I have worked in the field of aging for over 30 years and am now myself 66 years old, and so often feel like I am talking about myself when I do workshops. Today, I want to talk to you about an issue that I feel is really important and one that is not talked much about, and that is older adults and substance use. And I feel like I call it the invisible crisis because I feel like it is just that. It's one that we're not talking about. It's one that we talk about in terms of young people, but not often older adults. But it is very serious. It can be life-threatening serious. So I'm going to talk, and then, like I said, I'm going to check my time and make sure I leave 10 to 15 minutes. So here we go. You'll see me kind of looking over this way because my slides are over on that screen. All right, and I have to click to move them. So this is kind of our journey today. I want to talk about the importance of the topic, why we should care. I want to talk about the signs of substance use in terms of elders, why elders are at high risk, the age-related changes in our body that are going on that have an impact in terms of the medications that we take. In the packet that Mike sent or that you can download, I have the article from American Geriatric Society on the Beers list, which I'll be talking about and explaining. Then I'm just going to go through a couple of screening instruments, some approaches to treatment, and then kind of how we move forward. All right, so why is this important? So I know that probably everybody has heard this, but just in case, I like to go through it. And that is the fact that one of the reasons it's so important is because of the baby boom generation, which I'm a part of. We were born between 1946 and 1964, and we are the largest generation ever to come along. Millennials will outnumber us, but as of now. We still have about 73 million of the 78 boomers that are still alive today, and more than 10,000 turn 65 every single day and have been for quite a while and will continue to do so until 2030. So it's a lot of older adults. And then you can see by 2030, the population will be about a fifth. And that's the highest ever. We have never in America had a percentage of elders that high. So there's a lot of a lot of older adults, and the issue becomes that we lack professionals who have had training. And this is nothing negative to any professional, whether it's a physician, a nurse, social workers, etc. It's what we have worked on for 30 years and tried to increase the number of people that are trained to work with older adults and that know older adults' bodies, etc. But it's still very hard to get people who want to focus on older adults, and that's a whole nother kind of workshop. So in terms of boomers and substance use, though, there's things that make us just a tad bit different. And part of that is the fact that we were called the drug generation. And I still remember in the 60s how all of a sudden I was hearing so much about drugs. So that was very high for us. The use of drugs, the availability of drugs, etc. The other thing that contributes to this is that the drugs that are given for pain now, many of these prescription narcotics are very addictive. And so although someone will go on them because of back pain or whatever it is, oftentimes they stay on them too long and become addicted. And so that is definitely an issue. And then those who are 60 plus, when they do develop a dependence, it really is more for alleviating physical or psychological pain than just the thrill of getting high. And I think that's an important thing to consider when we look at older adults and the differences as to why they would take drugs. So people often say to me, well, you're just talking about people who already have an addiction, etc., and now they're just getting older. So that's what you're talking about. You're talking about people that age into a later part of their adulthood, and they already have an addiction. Yes, and those are referred to as you can see, hardy survivors. So those all are older adults who have been using drugs for years, long before they reach the age of 65. But it's really important to be aware, and oftentimes people aren't, that there is also late onset, and that occurs more often than most people would imagine. And these are older adults who develop the substance issues after reaching 65, meaning that they start drinking alcohol and having trouble with that after the age of 65, or opioids like I talked about because of maybe pain or whatever. So we know that it is not simply people that are aging in, but rather there are issues that often lead to people starting after the age of 65. So what are the issues for elders? One thing, and I'm going to just kind of go through what the issues are, but I'm going to go deeper here in just a bit. So dose level sometimes is more than prescribed. And let me say, I want to say at the onset that I don't believe in non-compliant patients. So people say, oh, they're non-compliant, they don't take their medicines like they're told to do. Yes, some people maybe do that, but for the most part, a lot of what we see that can become addictions is due to the fact that older adults can't see the prescription bottle, it's too small to read the writing, or they have so many prescriptions that they can get them mixed up, etc. There's a lot of reasons why an older adult might be taking a dose that's more than what's prescribed, besides just maybe a substance use problem, etc. But that can lead to one. A longer duration than prescribed, taking them beyond the time that is prescribed. And sometimes that can be the way that they could do that is by going to a different doctor to get more if their current doctor doesn't give it to them. Using it for purposes other than prescribed, and I think that, you know, says it. Using in conjunction with other meds or alcohol. And this is an issue because when sometimes older adults, if the bottle is not clear in terms about the alcohol because of the size of it, if an older adult has any confusion, etc., and may not read the bottle. And then it can also be that they get confused with other meds because they have so many prescriptions. And it also can be because we have specialists now. When I was growing up, you kind of went to your family physician and you rarely went to a specialist because we didn't really have them. But now we do. And not all records are necessarily, there's different electronic systems. So some systems don't talk to others in terms of healthcare charts. And so one doctor can be prescribing and not necessarily know that another doctor has prescribed a particular drug, and that can have interactions. Skipping doses or hoarding drugs, this can be because of the cost. Because, and I've had, when I was in practice, I had older adults who, when I spoke with them, they were skipping doses. They thought it would be okay. It would help the drugs to last longer. Because they just didn't have the money. And so that can be an issue. Or hoarding the drugs for the next time that there's an issue. And sometimes stopping them before they've really had their impact because they want to hoard them in case they get sick again. And that can be problematic. So I'm just going to give some trends. This data is not, it's 2017. And that's one of the issues I find with so much of the data for older adults is that it's old. I can find data for young, but I can't always find data for older adults. But I do have this data. And so 2017, just some facts. So combination of alcohol and medication misuse at that time was affecting 2.5 million elders. So that's a lot of older adults with misuse. Consume more than prescribed and over-the-counter meds than any other age group. And we know that over-the-counter meds, which I'll talk about, is also when you can't afford a prescription, you can't go to the doctor maybe you look on the web. I've known elders who have done this because they don't have the money or insurance, and so they'll look on the web and figure out something that they can take over the counter, but the issue is if you're taking other drugs, they could have a negative interaction. 14% admitted to the ER due to drug and alcohol related issues, as well as 20% of psychiatric hospital admissions. You know, this is important because, one, because I care about older adults, that says to me that we do have serious issues. But more than that, it's also about cost. We talk about, you know, that we have the highest healthcare cost in the world, and yet our healthcare doesn't rank as very high in terms of other countries. And when I look at this, what I see is that we need to do more prevention. We need to do more education. We need to get those percentages down for older adults and as well as for the cost. I think cost could better be served putting it into prevention, advertising on TV, letting older adults know about these types of issues that I'm talking about today. It'd be better served to put it there than on the back end when people, due to lack of knowledge about this topic, end up in an ER. Another thing that oftentimes people are surprised about is 50% of nursing home residents have some form of alcohol use disorder. And even though this is 2017, I have found other research that's been done more recently that shows that this still is a trend. With nursing home residents, they can get alcohol. And when I talked earlier about saying that older people don't necessarily do drugs for the high. It's more likely to be due to physical and psychological pain. We could see that very much could account for the high usage in nursing home residents. Widowers, not widows, widowers over the age of 75 have the highest rate of alcoholism in the US. And anytime I say this, people are surprised. They always assume that it is younger than 65. And notice that it says widowers, so it's men that tend to have the highest rate of alcoholism. And then you can see older adults are hospitalized as often for alcohol-related problems as heart attacks. And, you know, one thing that's on people's mind as we get older is our heart. And we don't necessarily think about the alcohol we consume, or that if we have a problem with alcohol, rather, that is as dangerous as a heart attack. Just some more statistics before we dive in. 89, so the Kaiser Family Foundation did do a survey, and the Kaiser Family Foundation, it's an excellent website, excellent information on health, and so it's very trustworthy. 89% of their survey reported taking prescription meds, and these are 65 and over. 54% report taking 4 or more prescription meds. 20% of those taking meds report not doing as prescribed. So this goes back to what I was talking about the hoarding or skipping doses due to cost. And then just the overall issues that were reported by the older adults were the drug interactions, the side effects, scheduling to take the drugs, and then taking them. I know that with my mom, I remember that she lived in a house, and there was some from Arkansas. There was a creek that ran between her house and my brother's house. They lived in the woods. And my brother had to go to work, as did my sister-in-law. But my mom needed to take meds during the day, and he couldn't keep driving back home to make sure she took them on time. And so that scheduling, we finally worked out a system. And now they do have technology with pill boxes that will set off an alarm or will only allow you to open for that time of day so that you don't mistakenly open another one. But that assumes that people have the money to purchase the technology. So that is definitely an issue as well. In terms of opioids, and this is 2017 data, older adults use prescription opioids at a higher rate than younger adults, and that goes back to when I was talking earlier about pain and about taking opioids because of could be physical pain, etc. And so it makes sense in many ways that older adults, because as we get older, we don't have to, but we can have aches and pains, etc., and be more likely to be prescribed opioids. Oh, I already talked about this. So, and then as I've said before, in general with drugs, but in particular with opioids, death is a huge issue, as is hospitalization or the use of the emergency department. Okay, so that just kind of, I hope, gives you information about why this topic is so important, that we address it and then we get this information out to providers, elders, etc. So, signs of substance use. I want to go over that because it's trickier in terms of older adults. So this comes from data from 2015 from, again, the National Council on Alcoholism and Drug Dependence. There are signs, and these signs, you'll see why this could be a little tough sometimes to discern. The issue is discerning the difference between the signs of substance use versus maybe signs of aging in terms of cognition or balance, etc. So one of the first signs is the solitary or secretive drinking. So not, if you think about it, a lot of times older adults are living alone. We know that the vast majority, only 4% of adults are in a nursing home at any point in time. People are living in the community, and oftentimes they are living by themselves. And so this solitary or secretive drinking, it really makes it easier. They're not necessarily going to work, and where they could be caught in terms of people smelling alcohol on them, etc. The ritual of drinking before, with, or after dinner, it depends on what that ritual is. Is it just one glass of wine, or is it that what was once just a glass of wine is more than that? Maybe they've lost interest in hobbies or any kind of activities that once were pleasurable. Maybe that's due to the fact that they are older and not able to do some of the things they loved. And this, when you think about it, it can be due to several reasons. One could be depression. The other could be a lack of, maybe that physically you're unable to do something that you love, and that it hasn't been replaced with another activity, another interest, and so it's replaced with substances. Drinking in spite of the warning labels on prescription drugs, whether they're seen or not, or sometimes, people will put them, not sometimes, people put them in their little med containers. I have one. I put my meds in every week. And once they're in there, you might not remember what was on the bottle. And then the use of tranquilizers, and tranquilizers are pretty freely given. They're often overprescribed for older adults. Other signs could be slurred speech, if you see bottles, or if you smell alcohol on the breath, or change in personal appearance. Maybe someone was once very neat with their appearance, and now you're seeing that their hair's not washed, or they just are not themselves. It could be depression, it could be other things, but it's really important to follow up on that change in an individual. The chronic and unsupported health complaints. So if someone is constantly talking about, I just have this pain in my back, I have this pain in my back, it could be that they're saying that in order to get the drugs that they want. So it can be that there really are, they're not supported, and so, and maybe you question how the person's able to move about so well and have pain in their back or whatever. So paying attention. And of course, if people have chronic health complaints, we want to make sure we take them to the doctor, etc. But if they continue when it's not been supported. Hostility or depression, just that short temper, that real quickness, and maybe that's not somebody that ever really was hostile or angry. That can definitely be a sign. Opioids, certainly people that misuse opioids when they need another dose and they may not get it, that coming down can really lead to that hostility and crankiness and snappiness. And then memory loss and confusion. So this is tough too. So when you think about some of the things we talked about, it's hard to know if I'm unstable, is it that I'm using a substance, or is it that I'm unstable because of physical issues? Same thing with memory loss and confusion. So people with substance use issues do experience memory loss and confusion, but so do older adults. The memory loss and confusion could be to dementia, but it also could be due to the drugs that people are taking that are prescribed because the doses are too heavy. And so it may not be a substance use problem, it may be an actual prescription problem. So those are the signs, and that's why you can see it's not always easy with older adults and to determine what is aging and what is maybe signs of substance use. And that makes it trickier for families, physicians, nurses, social workers, etc. So in terms of older adults, why would older adults be put at higher risk in terms of being overlooked, etc.? So one is ageism. And again, I am not saying negative things about healthcare providers. I see this as a system issue, and that is that we need to ensure that all family physicians, all social workers, all nurses, etc., OT, PT, all healthcare providers are trained on the material I'm providing you today. Because what happens with ageism is we have all these stereotypes about older adults, and so the stereotypes don't usually include that we start drinking after the age of 65, that we get addicted to opioids, that we are smoking pot daily. I mean, it can totally be overlooked, and that's because of the myths and stereotypes about older adults and about how for some reason we become very different at the age of 65, which is not true. We are who we are, and we continue to grow and age. And because it can mimic symptoms of other disorders, as I've already talked about. And I've already talked about the difficulty of distinguishing from changes due to aging. The other thing is the lack of education about substance use in the elderly population. I have talked to older adults, clients, who said, there's no substance use issues for older adults. And I'll ask why, and they'll say, I don't see it on TV. I see it about young people, but I've never seen any information, any kind of campaigns, and my doctors never talked to me about it. And I think that is that lack of training, but it is also a lack of society in terms of making that information available, making the information available at the doctor, on TV, having advertisements that talk about this. It's kind of like suicide. Suicide rates are highest with older adults, but what we see on TV is programs, marketing that's around lowering suicide rates for young people. And don't get me wrong, I think that's important, but I think that older adults are important too. So this is a problem. And then it's invisible because older adults, many are less likely to be in the workforce where it might be caught that someone is drinking or is high. And also trouble with the law. Many older adults are not so out and about, and in terms of driving and going places, and honestly, they're not as often are they stopped as younger people by officers due to issues. So that can be an issue too then, because you're not picking up on the fact that someone is driving and it's their driving's erratic due to drinking. An officer without training is more likely to think that it's erratic because they're an older adult, and that is the ageism piece. And with officers, it's the same thing, it's lack of training. So I just want to have a caveat, because I just don't think we should blame people when the system has not provided that education and training. So, the higher risk of med use is also, that puts us at higher risk, is because of we're more likely to experience pain as we get older, sleep disorders, being prescribed medications to sleep, anxiety, cognitive decline, depression. And let me say, these are not common among older adults. People always think, well, older adults are depressed because they're older, and that's not accurate. So, but these are things that can put us at a higher risk. All right. So now I want to talk about age-related changes, and this is pretty key. And this is a part that I think is so important for us to know about as older adults, but also providers. There are 4 changes I'm going to talk about: drug absorption, distribution, metabolism, and elimination. So as we get older, our body is changing, and our body is aging too. Our organs are aging. I always think about it like a car, brand new. You know, when you're born, you're good to go. All the parts are freshly made, but you know, the car gets older and different parts then also age. It's the same with our body. Even if we're healthy, our organs are just older. So what we see with drug absorption is the fact that, one, we have decreased stomach acid that would help to break down the drug. Our flow through our intestines slows down, which means the drugs stay in the system longer. The emptying of our stomach is slower, so the drugs are staying in our stomach longer. And so then the result basically is there's the rate of breaking down is not happening. And so instead what we see is that they're being absorbed. They're much more likely to be absorbed. And because we have this extra layer of fat inside of our body as we age, doesn't matter what you look like on the inside. This is on the outside. This is on the inside. They also can be absorbed in that fat. So if I want you to think for a moment about, like, when I had my son, you know, when he was a baby and as he got older, you know, how much of a dosage that my doctor would prescribe was smaller because his organs were smaller. So he had to have a smaller dosage. But as he grew and eventually became an adult, then his dosage could go up because his organs were fully developed and larger. And so there was a need for a higher dose than he was getting as a child. But the same thing then, our body keeps changing. It's not like it stops. And so as we age, because of those body changes, the dosages being given should be readjusted. And that is what often doesn't happen. What happens is we are given the same level of, same dosage as when we were younger adults or adults, not older adults. And so you can see where that's problematic. If these drugs are being absorbed at greater rates, then we should have less of a dose because we need less of a dose because of the absorption. The distribution of drugs, it's different for older adults. As you can see, the amount of water in our body decreases and our body fat increases, like I just mentioned. And so drugs that dissolve in water, they're going to be more concentrated because there is less water in an older person's body. Drugs that dissolve in fat accumulate and the effect lasts longer. So again, now you have toxic reactions. So you're taking a prescribed medication and you're taking it correctly. And yet what can happen is that you could have a toxic reaction because the dose is not adjusted for the fact that you are older, that your body's older. Metabolism of drugs. So medications travel to both the liver and some to the kidney, and they go there to be metabolized, that is broken down, right? And the job of the liver is to filter out much of the medications before releasing them into the bloodstream so that they can be effective. And what this does is it modifies that drug to permit elimination. But the liver, if it's older, it's not going to function the same, and so it's not going to do the modifying of the drug to permit the elimination, or not as much. Aging can decrease the enzyme activity of the liver, and so you're not going to have the liver's not going to do what it needs to do to break down and filter out drugs. And then, as you can see, same thing. more medication in the bloodstreams, and so you're going to have these reactions. And then the last thing is elimination. And so the kidney is kind of, that's where we eliminate our medications. That's kind of the main organ for that. But our kidney, it just functions slower as we get older. It's less efficient. So again, more of the drug remains in our system. So as you can see, a big issue is that our body, our older bodies can't really handle the same dosage levels of drugs as we could when we were in our 40s, etc. But the other thing is the type of drugs that we can no longer tolerate. So you did get a handout. The American Geriatric Society is now handling the Beers list. And the Beers list, I just want to quickly say, this was a list that was developed in 1991, and it was by Mark Beers. And he was looking at the criteria of, in terms of proper and, appropriate and inappropriate drug use for nursing home residents. And so, because he found that the dosages were too high and that some of the medications they were receiving were problematic and they should not be receiving them anymore. He then, in 1997, updated it for the general population of older adults. And for years, so I said I've been in teaching, I've been in gerontology for over 30 years, and the Beers list has been something that we've used for forever. But it was taken over in 2011 by the American Geriatric Society, and they update the Beers list every 3 years. So let me give you some examples of drugs that can be problematic as we get older. Okay, benzodiazepines. So these are drugs that are basically used to treat anxiety, insomnia, delirium, dementia, behavioral symptoms. So, and really used a lot in nursing homes for people with dementia who have, maybe they are being verbally abusive or physically abusive due to the cognitive changes that are happening in their brain. And so oftentimes for anxiety, insomnia, the drugs that are given are Valium or Xanax or Restoril. The problem is that these are really dangerous drugs to give to older adults, period. And what we see is this, there's like, as we get older, this increased sensitivity to these medications, and they do stay in our system longer. And what happens is side effects are like cognitive impairment, delirium, dizziness, urinary retention. And so here are drugs that are commonly prescribed for older adults and yet are not ones that should be used. And there are others that are alternatives, or even I think about with nursing homes, for example, and people being given Restoril and other types of benzodiazepines because of behavior that they no longer can control because of the dementia. There are other solutions, and we know, I do workshops on how to work with people with dementia who are exhibiting some of these behaviors, because actually they're not problem behaviors, they're communication. Someone trying to communicate and just can't do it the way they used to. Now, the other drug that, these are just examples, you'll be able to look in the article and see them all, but anticholinergics, sorry, that's my southern tongue slipping. These are used to treat asthma, diarrhea, insomnia, COPD, urinary incontinence, and many other issues. And you could see many of these definitely could be experienced by older adults. So some of the things that people are given are Benadryl, Dramamine, Advil PM, and these are ones that you can get over the counter. right? Benadryl, I know now you have to sign because of people use it to cook meth, but still we can get the Benadryl and the Advil PM right over the counter. But these are very problematic drugs again. The changes are the lower the ability of the liver and the kidney to particularly break down these meds and excrete them. But another issue is our blood-brain barrier. So that kind of operates to prevent certain medications, et cetera, from going into the brain. It's that protection. But as we get older, there is more permeability. And so what happens is drugs that shouldn't get into the brain do. And so, but there are alternatives to that particular drug that don't. So my mother was taking one for her stomach ulcers, and it was one that crossed over, and she was experiencing confusion, et cetera. Her family physician changed it and put her on one that didn't. And so that's really important to be aware of too. And the Beers list makes recommendations. And you can see that these could increase falls, which is not good. So here are just some more that the Beers list says we shouldn't take. Tylenol PM, Unisom, Alka-Seltzer Plus, Effexor, Cymbalta, Elavil, antipsychotics. Many of these drugs are ones that elders take. They're prescribed or they're over the counter, and these are all problematic. So I'm not going to go into great detail with this screening to save time, but I do want to say that at this time we are not screening older adults as when they go to the doctor. I go to the doctor, no one asks me anything, and there are very short, brief assessments, and I sent those to you that are specifically tested and validated for older adults. So what if we did do some of this screening? And in terms of treatment, when we work with older adults, it's really important that people are trained in how to work with older adults around issues of alcohol, etc. Older adults are not children. We don't need to be treated that way. I know that sometimes I am treated that way, and people use that voice of, "Are you okay?" Like I'm a kid. But that's not the way. We are adults. And so if, let's say that I had, that my children suspected that maybe I had an alcohol issue, talking to me like I'm a kid or saying, you know, what are you doing drinking? I am not going to react well to that. You're my children. And I may not react that well with physicians, etc. So the one thing you really, for treatment considerations, is being supportive, non-confrontational, empowering, talking to an older adult to say, you know, Mom, I'm just concerned. Lately I've noticed, and, you know, can you tell me what's happening? So how can we do that? Because then it's more likely that I'm going to open up, and maybe I'll be more open to treatment. Focusing on coping with losses. You know, sometimes we know as we get older, I see more of my friends dying. I see all the time, you know, celebrities that, you know, rockers that die that I grew up with. I mean, there's a lot of loss as we get older. And there can be loneliness and there can be depression. So anxiety. So if we think about really listening to the older adults, it could be that there is a loss that we don't know about, and that is causing or a cause of drinking. Focusing on how to rebuild an older adult's support network to address the loneliness. How can we do that? And with COVID, that is crucial. And then linking with other services, but services that And this is an issue too. There's just not a lot of counselors who are trained in working with older adults. There's not a lot of treatment centers that are trained, that have people who are trained in working with older adults. So we really need to think about age-specific treatment, people being aware of the things that I've talked about today. And also being aware that there are reasons sometimes that there can be drug use, but there are also these age-related considerations where we need to think about the fact that don't just give material to somebody about a treatment center. Maybe it's in small print and I can't see it. Maybe you're talking to me as a counselor and you have a voice like mine. I have a high voice. So because we lose our higher frequencies, we can't always hear someone with a high voice. We need to deepen. We need to talk lower, and then in doing so, it's more likely that the older person is going to hear us. We do not need to yell at them. That just makes it all garbled. Distractions, if there are no distractions, like if you're talking to your mother, no TV on, etc. And going over materials, big print materials, together. We need to work on issues for older adults in terms of insurance, language, people where English is not their first language, having providers that can work with them who speak that language, lack of cultural competence, transportation, literacy, health literacy, and just literacy itself. So moving forward, these are my recommendations that I've been talking about forever. Awareness, let's have campaigns, let's educate people, let's change the curriculum. We are working on that at the School of Social Work. How do we get more of what I talk about into our classes on substance use? Culturally appropriate screening tools. They're all right now aimed at the dominant society, and we need different tools, advanced screening tools, interventions, integrated treatment models. These are all things that are important, and these are all things that we can do. It's feasible, we can do it. So I'm going to stop there and left 13 minutes for questions. So I'm ready, Mike.
Okay, Tracy. Well, here I have one right away here. It says, I'm surprised about the 50% alcohol abuse figure in nursing homes. Now, I don't know if nursing homes included senior living facilities, you know, less restrictive, but how are people getting their alcohol? Are they coming into the facilities with drinking considerations? What have you noticed in your work?
So what research is showing on this is that they get it in different ways. So nursing homes don't really restrict alcohol necessarily, so people can have it. Their families can bring it into them. They can pay staff members, these are some of the things that we're seeing happening, paying staff members to pick up a bottle or two for them. It's easy to secretively drink because oftentimes you're in your room and there's so understaffed facilities that people are not always being checked on, etc. So getting the alcohol and using it, we found is way easier than we thought. And then there's the issue of, because they're understaffed and because of ageism, and the age-related changes being so much if I'm drinking, I'm stumbling, or at least I don't drink anymore, but when I did, I stumbled. And I couldn't remember things and I was confused. And so people could say, well, those are just signs of aging. So, and maybe not get close enough to smell alcohol in their breath, or even if they do, not thinking it is the alcohol that they're drinking too much and that's what's causing the issue.
Here's another one then. What are alternatives to Valium and some of the others that you mentioned for elders with panic attacks? The doctor just says to cut the meds in half, or perhaps the elder is willing to do counseling. What other things could be suggested?
So I'm going to bring up, excuse me. Okay. Let me scroll down. This is the beers list that I gave y'all. And this is going to be way too hard to see, I think, online. But what this will do is this talks about the alternatives, because I don't have them right off the top of my head, and I would not want to say, because if I say the wrong thing, that could be more dangerous than me just saying that I don't know them by heart. But then the nice thing is that this does go through and discusses. You can see there's just pages because it talks about the different types of drugs, and then it talks about alternatives. The other thing is checking with, so I will say that pharmacists, that's another really great resource. I worked with United Way here in Dane County, and with other professionals, doctors, nurses, etc., on developing a program that is still in effect, and pharmacies are participating in, where you can take all your meds in, and the pharmacist will go over them. They'll look at the dosages, and they'll say that dosage is too high for someone your age, or that's not a drug you should be taking. This is a better drug, and you need to talk to your doctor about it. Pharmacists are so knowledgeable. And the other thing is because, and some of this, you can do this, there is a sliding fee scale, and I think that they even will do it for free if necessary. But I definitely think that pharmacists are a great way to go. And then after, the pharmacist will write up a report, and then you can go to your doctor with that report and talk with your doctor about a different drug. The other thing that I highly recommend is, I think family physicians are great, don't get me wrong, but family physicians are trained as family physicians. And so geriatricians are doctors who are trained to work with older adults. And we switched my mom from a family physician to a geriatrician. It was amazing how much her confusion and her health improved. And it was the medications. So geriatricians are helpful. So you can definitely look at this list, but I think talking to a geriatrician or going to your pharmacist with your meds and have them just checked would be good.
Okay. Here's another question. For someone that is a lifelong substance abuser with both dementia and substance abuse in later life, do you have any suggestions for conversations with physicians on medication regime?
So I guess I would want, so the person has dementia and the person also has a substance use problem. So the dementia, is it in early stages? So maybe you could type that into chat because I need to know just a little more. Is it in the early stages where the person is still aware, such that if they, that they're not asking for alcohol or whatever it is?
It says mid-stage. They have activated POA-HC.
So in cases like that, so this is tough, and I think that working with the doctor is really important. So the mid-stage can be tricky, just like the early stage, in terms of people with different dementias. There's still an awareness. It's not like somebody has no awareness. They may not be able to communicate, but so they may still, and of course their body may be craving. Talking with the doctor and looking at how to begin to safely remove the alcohol or whatever, because the thing about it is that if some people will say it doesn't matter, they have dementia, but it does in terms of it will give even more confusion to the person with dementia. They're likely to fall. There are other hazards. So I would really work with the doctor on and being honest about the issue, and then slowly weaning the person, but doing it with a professional.
So Tracy, the questioner mentioned specifically Wernicke's alcohol dementia. Is that I have never heard of that. I'm not a have no idea what we're talking about here. I'm sorry.
You know, I have heard, but I will be honest in that I don't either. So I am always honest when I don't know something because I don't want to give incorrect information. I know the damage alcohol can do to the liver. So I'm wondering if in this case, I just don't know that much about it. Mike, if I were to send you some information, can you send it out to the attendees?
I'd be happy to.
Okay, so that I'm writing it down. And I will send that out and Mike will give it to you.
Any other questions? Please enter them in the chat or in the question tool, and still got a couple minutes. Very fortunate to have you today, Tracy. It's always interesting. I heard your previous presentation a few months ago, and I mean, you need several times, you know, to hear this material before you really start absorbing it. There's so much detail.
There is, and you know, it's sometimes I do 3 or 4 hour presentations on this and that, because there's a wealth of information. So I'm also condensing it into an hour. But I feel like if I get this much out and people talk about it with their doctors or talk about it with other older adults, other providers, I'm happy with that.
Okay. Well, I don't see any other questions coming in. So let me just thank you again for a fantastic presentation. And we'll get our next presenter set up. We'll start at 11 o'clock. We'll take a few minutes to get Officer Jennison going. And thanks a million, Tracy. Really appreciate it.
Thank you. And thank y'all. I can't see you, but thank you very much for being here. I appreciate it.